As many as 1 in 3 women are going to experience painful sex at some point in their life. They are often diagnosed with vulvodynia, vestibulodynia, or vaginismus, which are 3 medical diagnoses that are commonly associated with the symptom of painful sex. These 3 diagnoses all mean something different, and it's important to distinguish between vulvodynia, vestibulodynia, and vaginismus because they each require different treatments. In today's video, I'm going to talk about the differences between these 3 diagnoses and, most importantly, what you need to know to help yourself get better. The reason I want to talk about the differences between these 3 things today is because they can incorrectly be used interchangeably. And the differences really do matter in terms of what is going to be an effective treatment for somebody. Patients are getting diagnosed online by themselves by physicians with varying degrees of experience with vulvar health, and sometimes by people who are just in their circulating world who may be like, hey, I think you may have this. So when we're looking at how patients are discovering what's wrong with them, it's important because some people may have had a doctor who's completely informed, some people may have a doctor who told them to go drink a glass of wine, and somebody may have figured this out themselves. Regardless of how people arrive at the diagnosis, it's important to know that people can get past this and will get better, but we need to really understand what caused the painful sex in the first place and what is the actual diagnosis. If we start with vulvodynia, it is basically a symptom descriptor. Vulvodynia means pain in the vulva. The vulva includes the clitoris, the labia majora and minora, the area in between them, and the vestibule. Why that's important is because that is a lot of surface area. The nerves that innervate the vulva are multiple. There's the pudendal nerve, the ilioinguinal, the genitofemoral. The pelvic floor muscles are also associated with vulvar health, and then there's also hormonal factors that come into play as well. So vulvodynia describes the entire urogenital anatomy. If this becomes dysfunctional, there are multiple causes of that. The vestibule is part of the vulva. So when we are describing vestibulodynia, we are describing a very specific piece of the genital anatomy that is compromised by what is called the vestibule. It has clear outlines starting at Hart's line and working its way towards the vagina, and is actually one of the most common causes of painful sex. Many vulvar health experts understand the difference between the vestibule and the vulva, and also are aware of certain little fun facts, like the vestibule is derived from a different layer of our developing cells than the vulva. And that means that it comes with a different separate set of problems. The vestibule is responsible for about 1/3 of our lubrication when we're aroused, and the vestibule also houses many of the glands that produce our lubrication. The vulva does not. People with vestibulodynia also fall under the diagnostic umbrella of vulvodynia, but it's just a more specific piece of their anatomy that has different physiologic properties. So the vestibule is dependent upon estrogen and testosterone to maintain its health, to help us be able to lubricate, and it's also very closely connected to the pelvic floor muscles. One of the leading causes of vestibulodynia are hormonal insufficiencies. A second cause of vestibulodynia can be pelvic floor dysfunction. How do we know if the pelvic floor dysfunction is causing the vestibulodynia or hormonal insufficiencies are causing the vestibulodynia? Well, most often it's both. And looking at someone's history and carefully listening to our patients will help us figure out what are their background causes. How did they end up with this type of pain? If there are hormonal causes of vestibulodynia, treatment that is successful is going to involve both medical management to straighten out the hormonal problems, as well as pelvic floor physical therapy to address the musculoskeletal problems. In people with vulvodynia, there can be a number of other factors that are involved, not just the hormones and the pelvic floor muscles, which is more common with vestibulodynia. As I mentioned, vulvodynia, vestibulodynia, and vaginismus all are associated with painful sex. Vaginismus is technically defined as an involuntary pelvic floor contraction that results in the inability to achieve penetration. Vestibulodynia can cause pain, which can interfere with penetration, but that's different than the pelvic floor muscles being so tight that physically a woman cannot insert anything into the vagina. Many women who are diagnosed with vaginismus may have vestibulodynia or vulvodynia, and depending on who diagnosed them, unfortunately, the physician may not know the difference between the three. If somebody has true vaginismus and the muscles are physically so tight that penetration is not achieved, something like pelvic floor physical therapy and vaginal dilators are going to be very important for their care. If somebody has vestibulodynia, which has compromised tissue at the opening of the vagina, a dilator and sometimes internal pelvic floor physical therapy is going to be provocative and painful, and it may not be therapeutic for that woman until the hormonal insufficiencies are addressed, and then we can move on to the muscular dysfunction. We must separate out who has skin issues that need medical treatment, vestibular issues that may need medical treatment, versus people that just have pelvic floor dysfunction, in which case medical management may not be as primary in their treatment plan as something like pelvic floor physical therapy. I suspect that a lot of the things I'm saying may make sense to my viewers, but also many people have been given all of these diagnoses. How do we know what you really have? It comes down to patient history, a visual exam to physically look at the skin of the vulva and the vestibule, and then a digital exam where we can examine the muscles. After we do these things, we can come up with how someone developed their symptoms, what are their primary factors of the symptoms, and then the treatment plan that they need to undergo to address it. If someone with vaginismus really has vestibulodynia, certain treatments may not be effective and they may be painful. If someone with vestibulodynia really has vaginismus, the same thing can occur. Treatments are not going to be effective and they may not be getting the right help that they need. With careful coordination between patient care and treatment, we're able to help our patients figure out what they actually have and then work with them to make sure they're getting the help they need. These symptoms and these diagnoses are understandably scary for so many people. They don't need to be. It's important to really examine what is happening, and we can usually figure out why someone isn't progressing. They might need another provider that isn't yet part of their treatment plan, or they might have the wrong diagnosis. I've put links in the description below to help you get the care that you need.